Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. And we have a great guest on today, Dr. Jonathan Kaplan. He is the CEO and founder of BuildMyHealth. Doctor, welcome to the program.
Thanks for having me.
So, Doctor, we're going to talk about chronic conditions and more so obesity and the use of GLP-1 therapy, I should say, in this program. So let me just start off by providing a little bit of context of chronic conditions in the U.S. specifically. So currently, 90% of our national spend on healthcare, which is $4.5 trillion, is spent on chronic conditions. And the two that are most related to this situation is obesity and diabetes. Of these chronic conditions, obesity, 20% of children and 42% of adults are obese. And out of that, 38 million Americans have diabetes and 98 million have prediabetes. In today's world, we have more chronic conditions today than yesterday. However, GLP-1 drugs or therapies, as we are going to talk about today, seem to provide a very significant impact to the obesity epidemic. Losing weight manifests itself in mitigating diabetes, mitigating cardio conditions, and things of that nature. It's, to me, my father had diabetes and had every complication imaginable. He was obese, he had diabetes, 2 amputations of both legs, 1 arm, 2 fingers, had dialysis at home. I know all too well about how to convert a dining room into a bedroom, putting a ramp on the house, installing a bathroom downstairs. You know, there's many more costs associated with the therapy and an emotional aspect of it for the family in context of what the worst case scenario is. So that's where I come from in this conversation, is that worst case scenario. Diabetes doesn't hurt to some degree. Obesity doesn't hurt to some degree, but it has major, major ramifications, as you can imagine. So with all that, Doctor, tell us a little bit about yourself and Build My Body and what you're doing in the context of GLP-1 therapy.
Certainly. Yes, I'm Jonathan Kaplan. I'm a plastic surgeon based in San Francisco, originally from Louisiana. So if you hear an accent, that's where it's from. But you might ask, why is a plastic surgeon? Actually, you might ask, why is somebody from Louisiana in San Francisco? My wife and I moved here from Louisiana 11 years ago. But you also might ask, why is a plastic surgeon involved in weight management? Well, we had a lot of patients coming in for tummy tucks and body contouring procedures. We have our own operating room in our office that's accredited with board-certified anesthesiologists. But we had patients coming in, their weight was too high. They weren't good candidates for surgery, like a tummy tuck. And rather than turning them away, our nurse and nurse practitioners suggested that we start a weight management program. And so that's what we did, offering coaching and phentermine initially. This is a few years ago. And then we got access to semaglutide and tirzepatide, which are the active ingredients in Ozempic Wegovy and Mounjaro Zepbound. But we were getting them from a compounding pharmacy, which is legally allowed for the compounding pharmacies to make the active ingredients in these name brand drugs that are under patent protection, because they're all on an FDA shortage list. So the FDA says if the name brand drugs can't be produced in enough quantities to support Americans' needs, then compounding pharmacies can fill the void and make the duplicate. And by law, they have to be the duplicate. They can't be some quasi knockoff. And so that's where we were getting the access to these medications from compounding pharmacies and offering it to our patients. And then our weight management program really grew exponentially. I mean, we've treated over 1,000 patients. We have over 600 patients in our program currently, where we offer them either semaglutide or tirzepatide. We also offer them free coaching as part of their monthly membership. And we also provide them with free treatment of any of the most common side effects they may have from these medications, which we can talk about all of that. But these medications really are amazing. They're incredible. when we first started, we were very strict about the BMI parameters. If somebody had to be truly obese or have to have obesity-related conditions like high blood pressure, or diabetes, or sleep apnea. But after we were treating all these patients for over a year and nobody was getting these most serious conditions or most serious side effects, we realized that the benefits of these medications significantly outweighed any of the risks. People still get some of the most common side effects like nausea, vomiting, constipation, diarrhea, burping, bloating, abdominal pain, reflux, but those are all on average mild, treatable, and time limited. And we treat all those side effects if they have them, if the patient has them. But overall, patients stay on these medications because, again, they're just so effective. So that's how I got to San Francisco. That's how a plastic surgeon got into weight management. And it's really been just incredibly satisfying for my patients, for me, because, when you do a cosmetic procedure on somebody, that's very self-gratifying for me and for the patient. But you can only do so many operations in a week, whereas we can treat so many patients with obesity or who are trying to lose weight. And because you can treat so many more patients, it's so much more gratifying to hear all these great testimonials and stories from patients who say that's changed their life.
So when you're talking about a GLP-1 therapy or the equivalents of through compounding, we hear there's obviously been some questions about the effectiveness of the compound versus the true drug, if you will, the true therapy. Give us your insights on the difference between the two.
So what we're talking about with the GLPs, the GLP-1s, that's just the name of the naturally occurring hormone that the body produces after you eat a meal. Your body, from your intestines, your body releases these hormones called GLP-1s, glucagon-like peptide. And that is supposed to suppress your appetite. As we get older, maybe become more insulin resistant, those GLP-1 hormones don't work as well. And that's why this class of medications, which, by the way, has been around for over 20 years, that's why they work, is they basically mimic those naturally occurring hormones in the form of GLP-1 from the mimicking medication of semaglutide, or tirzepatide, the active ingredient Mounjaro and Zepbound. One of the reasons they think it works a little better is it not only mimics GLP-1, but it also mimics another naturally occurring GI hormone called GIP, which is gastric inhibitory peptide, or glucose-dependent insulinotropic polypeptide. It's a mouthful, but anyway, it mimics GIP and GLP-1, and so that's why those medications work so well. As far as the compounded versions of these, they really are by law an exact duplicate of the active ingredient in the name brand drug. And the compounding pharmacies aren't just making these in their backyard and things like that. These medications are coming from FDA registered manufacturers. So they're under those manufacturers under the oversight of the FDA. They are able to get the formula that's made by Novo Nordisk or Eli Lilly for semaglutide and tirzepatide respectively, because these are patented medications. The formula is public in the public domain. So the FDA registered manufacturers get the formula, they make the medication, they provide it to the compounding pharmacies who have licenses in the states they ship the medications to, and they have licenses from the State Board of Pharmacy. So the entire supply chain really is legitimate. The reason compounding pharmacies get a bad rap is because the FDA, who licenses compounding pharmacies, gives them a bad rap because they're talking out of both sides of their mouth. They're saying, oh, be careful with compounding pharmacies, but we license them. And when they're talking about all these different FDA alerts talking about compounding pharmacies, what they're really talking about is the pharmacies that are producing research grade semaglutide or tirzepatide, which there are companies that can legally make research grade materials that aren't under as much oversight. There could be a lot of impurities, but they're not meant for human use, and people can actually get it online without a prescription. But again, it's not for human use, and you really don't know exactly what you're getting. There's a lot of impurities there. Whereas the compounding pharmacies that we're working with, they are, again, getting the medications from an FDA registered manufacturer, and they have a license from the State Board of Pharmacy in all of the states that they're registered in. So again, big difference between what you hear about online as far as just getting medication without a prescription, big red flag with impurities, versus what we're getting, which is legitimate active ingredients that are duplicates of those name brand drugs. The big difference, honestly, compared to the name brand drug, is what you get from the compounding pharmacies comes in a vial, not in a fancy injector pen. And even in that case, it's no different than the lowest doses of Mounjaro and Zepbound now, because Eli Lilly's now providing those lower doses in vials to try and keep up with the shortage.
Interesting. So let's talk about how this benefits a medical practice, and we'll get to the obvious of how it benefits the patient. Management of chronic conditions is a huge effort in the U.S. Right? We have these virtual modalities now called chronic care management or remote patient monitoring and things of that nature, and a lot of doctors are adopting them. It would seem to me that if you have a high population or any population thereof that where the patient either has diabetes or specifically obesity, that this type of program could be incorporated into a chronic care management program. Is that a fair assumption?
I think it's even broader than that. I really think that these medications are the biggest thing since penicillin. Just like penicillin was the first antibiotic that revolutionized, the treatment of infectious diseases. These medications are revolutionizing all of the different things that providers across America are treating. So even if you don't have a chronic care management program, any provider in America, whatever they're treating, the underlying cause is probably obesity. So I think it is huge, just like you're talking about. I think
we
it's
agree.
Bigger. And so, like, for example, let me just run through it. Like, you might see different providers offering these weight loss medications as part of their practice, as part of their chronic care program, possibly, or just part of their practice in general. And you might judge a book by its cover thinking, well, why is a dermatologist offering weight loss medications? Well, because one of the most common causes of acne is obesity. You might look at an OBGYN. Why are they providing this medication? Well, one of the most common causes of infertility is obesity. So if you treat those, the underlying cause, the obesity, you're going to address the infertility, you're going to address the acne. And in the case of ear, nose, and throat doctors who treat sleep apnea, well, instead of just giving the patient a CPAP machine, treat their underlying obesity and you'll get rid of their sleep apnea. So you're going to see providers from all backgrounds using these medications, nephrologists, because this is helping people with chronic kidney disease, hepatologists that treat liver disease, these medications are reversing fatty liver. Primary care doctors, internal medicine doctors, oncologists will be offering these medications because there are 13 different obesity-related cancers out there that if you treat the obesity, you treat the cancer. And of course, as I mentioned, as a plastic surgeon, we're helping patients who are trying to get even cosmetic procedures lose weight so they're in a better place to get cosmetic surgery, that they'll have or as far as body contour procedures, they'll have a better result. Or if they're even getting a facelift, they'll have a better result. So that's why this really does have a place with every provider, whether they have a chronic care management program or a weight loss program or whatever kind of program they're calling it. It's basically whatever you were treating. I think the program is whatever the doctor was treating previously, we're treating the underlying cause now. Yeah. And it's going to make a major difference.
And that might be the underlying issue as to why we have more chronic conditions today than yesterday, is because we don't treat the underlying cause, we treat the symptom, right? We manage diabetes, put the pump put the pump on and adjust the pump. So let's stop managing, because diabetes can be put into remission. There's many studies, I'm aware of some that are actually over in Ireland, where based on a chronic care management program, you can put diabetes in remission 48% of the time. It doesn't involve, with all due respect, doesn't involve GLP-1 drugs, but there are different ways of achieving that objective. GLP-1 adoption of GLP-1 therapies is certainly a very viable one.
And type 2 diabetes, which is the main diabetes we're really talking about here, is the one that's mostly associated with obesity. Over 90% of type 2 diabetics have obesity. And so that's what these medications are treating. I just want to make it clear that we're not necessarily talking about type 1 diabetes, which is due to a shortage or a lack of production of insulin from the pancreas. And so those patients do need insulin to live. We're not talking about those medications or those patients in this situation.
For sure. I appreciate that clarification. So the therapy in and of itself, reimbursable or cash pay out of pocket for the patient?
Well, as far as the name brand drug is concerned, these medications are expensive. So just like patients don't want to pay $1,000 out of pocket, the insurance companies don't want to pay that much out of pocket. And even if they're getting a discounted rate, they don't want to pay that much out of their coffers. So that's why, statistically speaking, most insurance companies are not covering this. Last I saw, there was about 23% of insurance plans are covering the cost of these name brand drug medications. They're more likely to cover it for type 2 diabetes, but they're not as likely to cover it for obesity. So that's But still, even people are getting access to the name brand, and so much so that there's a shortage, which is why compounding pharmacies are allowed to make the duplicates. And when it comes to the compounded versions, those are very typically not covered by insurance. So patients have to pay out of pocket for that. But the big benefit to these medications is not only are they more accessible because the compounded versions aren't in shortage, but the other big benefit, aside from accessibility, is that they're significantly less expensive than the name brand drug. So, for example, the name brand drug consists of, when I'm talking about the name brand drug, I'm talking about Ozempic, Wegovy, which are both the same active ingredient, semaglutide, made by Novo Nordisk. Ozempic is for type 2 diabetes. Wegovy is for weight loss, is the indication, versus Mounjaro and Zepbound. Those are both, the active ingredient is tirzepatide. They're both made by Eli Lilly. Mounjaro is for type 2 diabetes, and Zepbound is for obesity, but they're the exact same medications. So those are the name brand drugs, over $1,000 for each of those per month, whereas the compounded versions can be anywhere from $300 to $600 a month. I'm not saying it's cheap, but it's certainly less expensive and definitely more affordable. And I even did a study with the patients in my practice that they saved a lot of money by eating less on these medications. So they were able to look at their Instacart and DoorDash and Uber Eats receipts from the month before they were on the medication, the month after they were medication. It was clear they were saving money, which they can then reallocate towards the cost of these out-of-pocket medications in the case of compounded meds, since they're not covered by insurance. And that's what I had a separate company, Build My Bod, it was initially Build My Bod, then Build My Health, and now it's Dr. Well by Build My Health, which it was always about price transparency, which if patients can check pricing for healthcare services through their provider's website, then after they check the pricing, they can purchase non-surgical services. And then that evolved into subscription services. And so that's one of the things that I'm using my company in my own practice, but also for 150 providers across the country to help manage these programs for our providers. And yes, we're talking about the weight loss medications from compounding pharmacies, but our platform can support any subscription service through a compounding pharmacy for a patient. So if there's people are looking at longevity or wellness, like rapamycin or hair loss medications or NAD or testosterone therapy, estrogen therapy, those things that come from a compounding pharmacy that are offered as a subscription to patients, our platform can support the provider in offering those medications through our automation of technology. And essentially what we're doing is the way the direct consumer company works, where they're selling directly to the patient. Well, and then they might have a provider that acts as an independent contractor to do like an asynchronous or synchronous consultation and gets paid anywhere from $15 to $50 for that consultation. What we're doing is we're taking all those DTC tools, online automated tools, and we're putting it in the hands of the provider. And what we call our platform, our business model is provider to consumer, or PTC. So we're reestablishing that doctor-patient relationship, connecting the patient directly with a provider that they're going to stick with. They're going to have that continuity of care. So if they are having side effects with weight loss medications, then they have somebody to contact it might even be their existing doctor. They just didn't know they were using our platform. But that's what the big picture is here, is that we're automating these services for providers to restore that doctor-patient relationship, as opposed to the patient being connected to a DTC or a direct-to-consumer company, where if they really have any problems, who are they going to follow up with? They're going to call customer service, who's probably going to tell them to go to the ER or urgent care or something, right, and just overutilize healthcare even more so.
So what do you couple with the program? You prescribing a compounded duplicate, but you read reports online where the consumers are taking these therapies, but they're not really doing anything. I heard you did mention you have a lot of patients that are saving money by not eating this much. That's great, right? But there's a lot that take the med, take the therapy, but they're not exercising, they're not dieting, and then once they come off the medication, they reverse the action. Well, thoughts
all of
on
the
that?
above are true. Yeah, all of the above are true. So we definitely incorporate coaching into our program, and our providers and our network in the Dr. Well by Build My Health network offer coaching. But yes, patients are just human nature. You tend to if it works, if the injection once per week injection works, And it's easy to like say, oh, I don't need those other things. Because the truth is, they always talked about diet and exercise for weight loss, and it really wasn't always effective for weight loss because of insulin resistance and things like that. And your body set weight and your hypothalamus has gotten high, so you don't feel, it takes longer to feel full. These medications lowers that thermostat, so you feel full sooner, and so you do lose weight, and it is very effective. But we do offer coaching so that we can help patients with side effects. We treat the most common side effects, as I mentioned. They, if they're having nausea, we'll send them Zofran. If they're having constipation, send them magnesium, ginger snaps, or sulfur burps. Again, relatively mild and treatable. But then also we encourage the coaching part of the program where we're coaching them on diet and exercise, because with the diet and exercise, exercise is good for heart health, even if it's not necessarily going to help you lose weight as effectively as these medications. And as far as the diet, we certainly want patients to take in as much protein, even though they're eating less. We want to make sure that what they're eating counts. And so we don't want to increase their protein intake either through high protein foods or protein supplement shakes or the combination of both. And then, of course, the exercise is good for maintaining lean body mass, because that's another thing that people always attribute to these medications, saying, oh, you're going to have lean body mass, which is loss of muscle and bone. The truth is you're going to have lean body mass with any type of massive weight loss. So, but people all act like this is some predetermined fate. There's nothing you can do about it. So that's why coaching on diet and exercise, high protein foods, working out can minimize the lean body mass loss. So you're in a better shape. Now, the problem is that when you do get off these medications, even if you stick with diet and exercise, one of the studies that Eli Lilly did with Zepbound that they submitted to the FDA showed that even with diet and exercise, once you got off the medication, you still had a chance of regaining some weight. Not necessarily all of it, but you're still going to regain some weight. But obviously, continuing with diet and exercise is good. So because of the fact that patients can regain weight, we do implement in our program, in my practice, but also all of our providers, we have maintenance subscriptions where patients can determine that once they get to their goal weight, they might find that, instead of taking one shot per week 4 times a month to keep losing weight, they can switch to a maintenance subscription where they might find that if they take 1, 2, or 3 shots a month, that may be just enough to suppress their appetite for the whole month and help them maintain their weight. And it's really interesting how these medications, the patients really can kind of adjust and determine what works best for their body. And so that is one of the things that we do offer patients is maintenance subscriptions, where we're sending them less medication for fewer shots, but it also costs less. And so it's more tenable for them to continue doing that for as long as they feel like they need to. But there's no question that they should keep sticking with a good diet and exercise program. It won't be as effective as the medications for weight loss, but diet and exercise are still good for other reasons, cardiac health and things like that, of course.
For sure. So benefit on the provider side, a new class of business or new service class for the practice. A little different because it may not be the classic reimbursement model. It's direct cash pay, if you will, directly from the consumer. Briefly about what with the program, not just the prescribing of the therapy. What should a consumer expect to pay for a program such as the one you've described?
So with our platform, all of our providers can set prices differently. They can choose to do whatever they want. I guess they could do it based on their, the community they're in. But our providers through our platform automate these subscription charges. It's like a Netflix subscription where they use our platform to send the patient a link. The patient signs up, they're charged, the provider's notified. We connect the provider with the compounding pharmacies and then they place the e-prescribe the orders through our platform to the compounding pharmacy, and then the medication can be either shipped directly to the patient or shipped to the provider, who then provides it to the patient. But through all that process, we're automating that process to make it easy for the provider and get the patient their medications faster. And also one of the things that our platform allows is when the provider is choosing their pricing, they can do a few different things. They can have the same price throughout. So for example, in our practice, it's $500 a month for semaglutide. And then after 6 months, it automatically decreases to $400 a month, because after 6 months, we're probably not providing the patient with as much coaching, because whatever coaching they needed, they got in the first 6 months. They're probably not having side effects. So there's not as much support that is necessary. We're certainly there to provide it, but there may not be as much support necessary. So in our practice, it goes from $500 to $400 after 6 months, sort of like a loyalty program. For tirzepatide, the active ingredient Mounjaro and Zepbound, it's $600 a month. for the 2.5 up to 10 milligram doses. And then after 6 months, that goes from $600 to $500. So that's what we do in our practice. It's the same kind of flat rate until it drops off into that loyalty program. But other providers may start off at $200 for the lower doses, because that's one thing I haven't mentioned yet, is that these are once per week injections 4 times a month, but they start off on the lowest dose, and then each month they go up to the next higher dose, just like the name brand drug regimen. And the reason they do that is to minimize side effects, get your body acclimated to those lower doses before increasing. And because the lower doses are less expensive, some providers will start at a lower price point, like $200, and then each month or every few months, the price goes up. We don't want patients to be surprised in our practice that their prices are going up. We figure they're going to be happy if their price goes down. So that's why we choose to do a flat rate for those first 6 months, and then it drops off. Whereas other providers, they choose to start off like at a $200 price point, and then eventually gets up to a $700 or $800 price point, depending on what medication they're offering. So that's how it works with our providers for our patients. But the most important thing is that it's always less expensive than the name brand drug if you're paying out of pocket. I mean, of course, if you can get it covered by insurance, that's great. But even if you do get it covered by insurance, there may still be a shortage. You may have trouble finding the name brand drug at the pharmacy. We do support patients who are interested in trying to apply for or get insurance coverage. We have them fill out a questionnaire. We do a pre-authorization and benefits assessment for free for them. And if they get coverage, great. It's still we still charge a rate to do all the pre-authorization and all those things. And if they go to the pharmacy and they can't get the name brand drug, well, then the fallback is they just get the compounded meds from us for the same price that they already paid for their monthly membership.
So great opportunity for providers. Great opportunity certainly for the consumer, the patient, because they have a healthier tomorrow. We reduce the overall spend relative to the cost of chronic care conditions. And we changed the tide in that maybe tomorrow we'll have less chronic conditions than we have today versus
Absolutely.
So we have to change the curve is ultimately. And this seems like one of the most promising therapies that we've had in decades relative to our ability to change that cost curve.
Never been anything like it. As I said before, it's the biggest thing since penicillin. And if you want to be sarcastic about it or joke about it a little bit, penicillin, I mean, all that did, that only treated one thing. That only treated infection. These medications, they treat everything.
We have 1 minute left. Any closing words?
No, this has just been an incredible thing to be a part of as a provider for the last 16 years. This is really one of the most exciting things I've ever seen. I've never seen something that's so effective in the pharmacological space. And for providers who are in private practice or who are tired of being taken advantage of by the direct-to-consumer companies that are using them as independent contractors, or if you're an employed physician and you're just demoralized by the state of insurance reimbursement and how you keep getting denied, this is a great opportunity for you to treat a lot of patients, treat them well, treat them with safe medications, help them lose weight. Very gratifying emotionally and financially, of course, but also you're providing the patient with an amazing medication at a much reduced price, much more accessible than they can get on their own. Makes everybody happy. Everybody's happy on both sides of this.
Very interesting. We'll leave it there. Dr. Jonathan Kaplan, CEO and founder of BuildMyHealth. He can be found on LinkedIn. Any other social media?
Yeah, we actually have a big TikTok and Instagram following. It's at Real Dr. Bay. That's RealDrBae, because I'm in the San Francisco Bay Area, but it's BAE, not BAY. Real Dr. Bay on TikTok and Instagram.
Awesome. Doctor, thank you very much.
Thanks for having me.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, TheVirtualShift. I'm Tom Foley. Until the next shift.